This is a message to pharmacists like you who have cared for your patients through the healthy times and through the hard times. Throughout the COVID-19 pandemic, you were there to help patients, providing them access to the information, medicine, and the vaccines they needed to help stay protected. Now, as the threat of COVID-19 moves from the pandemic to the endemic stage, it's time to help your patients understand the importance of regular vaccination against circulating variants of the SARS-CoV-2 virus as part of a healthy lifestyle. While COVID-19 may not be top of mind for your patients, the threat of disease is still here. Hospitalization rates in the U.S. for COVID-19 increased by close to 217% in the summer of 2023, jumping from 6,477 hospitalizations in the first week of July to 20,538 in the week of September 9th through the 15th. Make sure your patients know that COVID-19 vaccines have been updated and are now available. You saw them through the pandemic. Now you can continue to help patients see that the ongoing threat of COVID-19 is something that we face together. Thank you to pharmacists everywhere. This message has been brought to you by Moderna.
You're listening to the Pharmacy Podcast Network.
In a world where one-size-fits-all medications dominate the pharmaceutical industry, precision medicine brings a ray of hope for those seeking customized healthcare. Pharmacists have a unique opportunity to help people in need of specialized testing to ensure medications work as intended. Welcome to PGX for Pharmacists, where we unravel the wonders of precision medicine and its potential to revolutionize the way we approach pharmacy care. Get ready to uncover the secrets behind pharmacogenomics and how it's transforming lives one genome at a time.
Hi everyone, my name is Banasa Rami, your host to PGX for Pharmacists podcast on the largest pharmacy podcast in the nation and one of the top 20 podcasts in genomics globally. If you're new to the podcast, well, hopefully you're not, I'm a pharmacogenomics medical science liaison and a mentor to pharmacists. Connect with me on LinkedIn and let's get the conversation going. I want to hear from you and how you're impacting patients, payers, or clinicians, and what you have learned throughout your journey that you want to share with me. So being a PGX expert and advocate requires going beyond a certificate and reading an actionable genetics report. It's about knowing how to connect with a patient, understand their health history, and be able to use the genetics data and research out there to help guide providers to make better treatment outcomes. So I'm super excited to welcome our incredible lineup of guests who are eager to share their expertise and their unique perspective. So get ready for an unforgettable podcast experience with this PGX Roundtable we have today. I'd love for each of our esteemed guests to have a moment to introduce themselves, share a bit about their background, expertise, and what brings them on this conversation today. So Christina, I want to start with you. I know you have faced many obstacles and traumatic events in your life, and I'm grateful to you and everyone else, of course, and the courage you have to continuously share your story in the hopes that bringing more awareness. So tell us a little bit about Christina and why you are such a believer in pharmacogenomics.
Okay, thank you so much again, Banaz, for having me and the rest of the girls here today and sharing our stories. So I'm a mother of 3 and a wife, and I have zero background in the healthcare world. My mother was diagnosed with stage 4 pancreatic cancer, and it was a huge shock to myself and my family. I basically, wanted to do everything that I could to help her and her situation. And unfortunately, it took a bad turn. So I'm here today because I want to share her story because it's unique. And I would encourage the rest of the world to hear and understand and and know that if they have a family member or a loved one going through something, that there's other sources and things that they can look into.
Well, thank you, Christina. I appreciate that. And then we also have amazing Karen. I know I remember meeting you, Karen, at Precision Medicine World Conference, or PMWC, this past January, I think. It feels like such a long time ago. And you were up on that stage sharing your story, and how you conveyed that message captured me. And I knew I had to grab you right off the stage and talk to you about that. So can you tell us a little bit about yourself and your non-for-profit?
Yes, thank you, Banaz, and thank you for introducing yourself to me after that Precision Medicine World Conference and the connections that I have made. Sadly, it's great, but also sad to have met Christina, because that means that we have a common connection, that we have a loved one who died from their chemo and not necessarily from their cancer. So I have become a passionate patient advocate since 2014, when I lost my mom to her chemo, 5FU, not her cancer. She had an unknown DPD deficiency, which they could have tested her for before her chemotherapy and adjusted her dose or found a different chemotherapy. I am a patient representative to a few groups working to make DPYD genetic testing part of standard of care in the United States, as it is in most of Europe. I'm also a founding member of Audit, which stands for Advocates for Universal DPD DPYD Testing. It is our hope that we will convince the NCCN, the FDA, and other institutions that it's time to start testing patients before administering 5FU or capecitabine fluorouracil.
Well, I appreciate you doing that. I think we might have lost Karen a little bit, but we'll come back. So Joanne, you and Karen are both co-founders of the non-for-profit she was talking about, AUDT, but also an advocate for other foundations. So tell us how you got involved and what that means to you.
Okay, well, my story mirrors pretty much Karen's as well in terms of my husband's experience. He was diagnosed with stage 1 cholangiocarcinoma, which is bile duct cancer. He had a Whipple surgery, which is quite expensive, and it's about a 12-hour-long surgery. He was declared cancer-free when the surgery was over because it was a perfect outcome. But they started him on capecitabine just as adjuvant chemotherapy. And he started having some toxic reactions and almost immediately, which were far greater than we ever were led to believe would happen. And so over a period of just a couple of weeks, he was hospitalized and never left the hospital. He died about 3 weeks after we admitted him for the first emergency room visit. So I found out pretty quickly that it was DPD enzyme deficiency, although the doctors were reluctant to talk about it. They denied that that's what he died of. But after his death, I immediately got into both research on what this was all about. How did this happen? How could it happen at a major cancer treatment center, Oregon Health and Science University Hospital in Portland? At the same time, I was also encouraged to file a lawsuit, and I did so, which was finally settled last year. I could probably go into more detail after we finish all the other introductions. My introduction turned out to be a little deeper than I was planning to go into immediately. But so that is how I got involved in DPD. That's how I got involved with the audit advocacy group as one of the founding members. So I'll be happy to talk later about a little more detail about the lawsuit and what audit is actually accomplishing.
Yes, please. And I appreciate you doing that. Yes, we would want you to share all that. And then Christine, you're doing so much in this space as well, including bringing awareness to adding diversity and inclusion in clinical research. And just stimulation provoking great discussion. So I'll let you introduce yourself, because I think it'd be a long introduction if I do it.
Well, I'll try to keep it short. I'm a little bit different than all our other panelists because I am the individual that did the pharmacogenomic testing and found multiple different things in them. So just for a short introduction, I am a rare, undiagnosed patient still. We've spent my lifetime treating symptoms instead of the underlying cause. We're just not there yet. But in that process, I have all of my life experienced bad things from medications from the time I was a child. We've stopped medications. We've tried new ones. We've gone through the trial and error my entire life. The reason why I'm in pharmacogenomics was I was part of a research project at Stanford, the human-wide project, which actually gave pharmacogenomics access to us. It was from that test that I discovered that out of all of the compounds they tested, more than half of them I metabolized differently. And so I have damage from medications. I have 3 joint replacements. I have toxic encephalopathy, which is brain damage. And I've lost my night vision, all from standard of care for one of my conditions, although I'm not even sure that's one of my major conditions, right? So for me, after the pharmacogenomics test, we were able to change my care and treatment. We put some allergies into my charts for drugs that I should not be taking. We adjusted some of the other medications, and we put some on the list of never to take again. So it's really helped myself in determining that care and even the quality of life. The drugs that I'm taking now, not all of them, pass through that testing, but a lot of them we have been able to make different decisions on my care. And so I think it's really important. I testified in front of the California State Health Committee, I can think for a second, around access to pharmacogenomics for our Medi-Cal patients, because I do see the cost savings for having this test done early. I'm dealing with damage that will be a lifetime of damage that we will continually have to pay out for and treat. And we could avoid these things with simple tests. So I'll stop there. And
no, I appreciate it. No, and I think I wanted to talk about, this is one of the things we had discussed before, where the allergy section is hosted in your chart, and how, you were talking about a situation where it was hard to kind of locate that. And we'll talk about that. I'm excited about that. And then last but not least, we have Becky Winslow, a pharmacist who is also a subject matter expert on pharmacogenomics, to bring her insight as well. So thanks for coming on the show podcast, Becky, and sharing your perspective as a pharmacist. So thank you, Becky.
Thank you for having me, and I look forward to contributing to the conversation as it works for us.
Yes, thank you. So this goes for everyone, but I think maybe Christina or Karen, tell us if maybe our audiences are not too familiar with DPYD. Or maybe Karen, if you want to educate us on that, what it is and why it's important and why we should care.
Sure. DPYD is a gene that we all have, and it tells the body to make the DPD enzyme, which stands for dihydropyrimidine dehydrogenase. So individuals need this enzyme to process fluoropyrimidine chemotherapy, which would be 5-FU, fluorouracil, or capecitabine. And these are commonly referred to in chemo cocktails as Folfox, Folfiri, FOLFIRINOX, Capox. So this is a wonderful chemotherapy that got FDA approval in at least the 5U portion in 1962. It's a mainstay cancer drug in fighting solid tumors. Works wonders for many. But for the people that it doesn't work wonders for, it's severe suffering and death. So the National Libraries of Medicine says anywhere between 3 to 7% of the US population has a DPYD variant, which means you either need to have a reduced dose or find a different chemotherapy. depending on which variant you have. In January of this year, in the Journal of Clinical Oncology, there was an article or a study that came out that said 9% of the US population is at risk for this DPD deficiency. So when you have this deficiency, the cancer chemotherapy kills all of these fast turnover cells. And once you have it in your body, if you can't excrete it because you don't have this enzyme, then it ends up doing more harm than good. And it is a horrific suffering for patients.
Well, thank you, Karen. I think, Christina, you also were talking about you don't come from a clinical background, but I think you're pretty much an expert in that as well now, after all your research you had to go through with your mom, for your mom. And so you want to tell us a little bit about that and, what you tried to do, because there is an option if you are deficient and you can still you have that window of opportunity. So you want to walk us through that?
I mean, I noticed as soon as my mother was administered the chemotherapy, like Joanne had mentioned with her husband, and obviously Karen as well. And I'm so sorry, ladies, that you went through the very similar situation that I did, well, that my mother did. She completely was like violently ill. And I took her back and forth to the hospital. Within that, just within a day or two, I was going back and forth multiple times, and they would just give her, hydration and just say this is all normal, and that by the weekend, her chemo was given on a Monday, and by like Friday, they were telling me she would take a turn by Sunday and be better. So by day 7, I mean, she was declining so much. I mean, and again, violently ill. And I ended up taking her, she was being seen at the Westchester Sloan Center, Memorial Sloan, and Sloan Kettering. And I ended up taking her into the city where her actual doctor was practicing. So I went directly there. We waited hours in the emergency room there. And then they finally admitted her. And I had to unfortunately leave her. I have 3 children at home, and I had to leave that night. But by the time I got back there, I didn't get back there the following day, which would have been a Monday. By Tuesday morning, when I left her, she was walking and she had a full head of hair. And by that Tuesday morning, she lost all of her hair. And she honestly, they didn't think that she was going to even make it through that night. So I was in complete shock by her presence, like, how she was completely not her, and it was a huge shock seeing how I left her on that Sunday night there. And a very long story short, which I'm sure we can all conversate about, I was doing tirelessly researching, and I had mentioned DPD because I had read about the enzyme deficiency. I had mentioned that to the doctors that Sunday night. There was no mention of it on that Tuesday. And that Tuesday morning, I demanded to speak to someone else. And then they finally said that they were going to go ahead and do the test and send it to, oh God, the name is slipping my mind, but everybody knows it. The center, they sent it to one of the centers. And it took 10 days to get a response back, the results. Turns out, yes, she was partially deficient. However, before those 10 days were up, by I think maybe day 9 from the chemotherapy being administered, I was working tirelessly to find some answers. So I was, chatting back and forth, messaging through the app, with the doctor saying, she needs selenium to bring her neutrophils up. And I was checking her blood count every morning and going there every day. And I found a website, strongmom.com, where it was a gentleman who lost his wife. And it was from this. And they used a drug called Vistagard to reverse the toxicity. But the Vistagard drug it's an antidote. So it's supposed to be delivered within 3 days of the chemo being administered. And of course, we were outside of that time frame. So the doctors were hesitant to order it because of the efficacy issues. And I just had to really advocate for her and demand it. And by the next morning, they had it overnighted and the VistaGuard drug was provided to us. And that very next morning, she was putting a fork to her mouth. So I'll pause here and let more discussion happen. But basically, if this blood test can be just a simple blood test, which is required in Europe and and other countries, before this drug is administered, it would save lives.
Yeah, it took what, like how many days to get the result back? That's crazy.
To get the actual results back, it took 10 days. What is it? The Mayo Clinic. I couldn't think of it. The Mayo Clinic or whatever. It took that long, but so they were actually giving the VistaGuard prior to getting the results because I demanded it. And they weren't even giving it to her right either. So that's another thing I had to deal with the pharmacist because they were not giving her the proper dose even then.
Wow.
So it's just reminds you of how it really heavily involved you really need to be. And, I'm not saying, you can't trust doctors or anyone like that in the medical field. I'm not saying that whatsoever. However, you do need to research, as much as you possibly can, ask questions, get second opinions, and just advocate for yourself, because some of the things that they were calling me a doctor, and that was very unsettling to hear, they're like, oh, yeah, I'm like, well, you guys are trying to treat my mom here. And it's very unfortunate, but if it's something that can be avoided, why would we not?
Yeah, great question. Yes. Joanna, you wanted to I'm sorry, Joanne, you wanted to talk about something further that I think you were trying to do your short introduction there.
Well, I want to pick up on the VistaGuard issue.
Okay. Yes.
So David's mucositis was so extreme that he could hardly swallow. And at OHSU as well, they decided that, yes, this could be a DPD enzyme deficiency issue, but we need to get the test results back before we order the VistaGuard. So they had that reversed. Someone finally stepped up and said, okay, let's get it delivered as soon as we can. And it was 7 days beyond the close of that window. So it comes in crystal form and it needs to be crushed and mixed with a food-based thickener and inserted through an NG tube. Not one of the nurses who was administering the VistaGuard knew how to do it. No one asked the pharmacy. They didn't do any research. They didn't try to find out what the instructions actually were. So it was a bit of a waste. He did have it. He was given every dose, but it was a waste because it wasn't effective at all. Anyway, that was just one issue that I wanted to bring up. I think VistaGuard is certainly effective, 98% effective, if it's given within 96 hours of the last dose.
Yeah, 96 hours, you're right. Mm-hmm.
Right.
And the problem with that 96-hour window is when we took my mom to the hospital, the emergency room staff is not educated the toxicity from this chemotherapy, when it's so crucial like DPD deficiency, it looks a lot like severe suffering, severe toxicity, right? Not that it can be life altering. And the window that you have to treat it in. And I think they thought that this VistaGuard would be, the golden ticket, but there's so many nuances. It has to be the time frame. It's expensive. Hospitals won't staff it or stock it because it has a 1-year shelf life. So once they decide they need it, there's another 24 hours when they have to get it overnighted. And then, as Joanne and Christina said, administering it takes also it's so new. I don't know if they're trained on that. So,
yeah, they're not. I was going in every morning to give it to her. After that first day, I was losing my mind because they weren't doing it right. And so I would and she did have the severe mucositis as well. And she could absolutely it was terrible. So they were thinking about doing the NG2, but since that was also dangerous, we did end up, I mixed it with, I think it was applesauce or whatever it might have been. And I just did whatever I can just to get a little bit in there. But yeah, I mean, she went from, they thought she was going to not make it through the night to at least being able to even get up and go to the bathroom, which was really huge, huge, huge steps. So I do believe that it did have some sort of effect, just from the reversal that I saw. But again, it wasn't even given properly, but whatever dose we did get in there, we did.
So, and then there's another issue that I want to bring up as well, and that has to do with the training that the nurses get or don't receive for the triage, for the phone calls that come in from the patients or the caregivers. They don't ask the right questions. I was told that I just needed to treat him at home for this huge list of toxic reactions that he was going to have, even though I said he's sick enough to come into the hospital. They assured me that he wasn't, that I should just go to the local pharmacy. So nurses, the triage nurses really do need to ask the right questions. How many times has he vomited or had diarrhea? Maybe you do need to take him off of the medication immediately. And maybe you do need to bring him in. So we lost about 3 good days at least in discovering what was really going on. And then, of course, the ER staff is not necessarily up to date on the chemo and what to watch for. They're simply treating each individual symptom rather than this toxic breakdown of his, this systemic breakdown caused by all of these symptoms. So again, it's much easier just to do the genetic testing before they start them on the chemo, because there are too many areas in which the dominoes are going to fall and the patient is not going to survive. So testing is where we start.
And can I comment on that as well? Because you guys are
please.
mentioning that before the treatment, you need to start that. But for me personally, I think it's way before you're even diagnosed with a condition where this test needs to happen. So for me personally, the damage that I experienced was from standard of care drugs. One of them was steroids, right? Prednisone. One of them was methotrexate. One of them was Plaquenil. These are drugs that we prescribe to people all the time. And the number of people that I talk to that have been on methotrexate and experience brain fog, but they're being told that that's normal. I don't know that it's normal in all of these people, right? We write these things off as symptoms and as part of the disease, and we're supposed to live with it. But I've had more damage happen from the medications than from my actual conditions. And those are things we have to think about. I have joint replacements because steroids or prednisone ate through my bones and I have avascular necrosis. If we can stop that, we use steroids to treat asthma in kids. We should know before we start taking these things what the effects are. And right now we deal with step therapy where we have you have to try all these drugs first before we give you what you and your doctor agreed on. If we have these tests, we can save costs there too. So my joint replacements, it's not a one-time joint replacement. After 10 years, all 3 of my joints have to be replaced again. The cognitive behavioral therapy that I have to go through for the brain damage is going to continue the rest of my life. And we're going to keep paying for these. But if we pay for this test early, before people are even diagnosed with a condition, we can save on that. And then the other drug that we haven't even touched on yet, the CYP compounds, I don't metabolize pain meds in the same way that other people do. And so I got dismissed. People think I'm a drug seeker because I'm seeking the one drug that is effective for me. But because there's no knowledge of pharmacogenomics and how different opioids can affect different people, those are the conversations we're not having. And so for me, I think way before I diagnose these, it should be done for everybody. And any treatment that you're getting, we're giving our kids drugs. I've been on drugs since I was a kid. I'm dealing with these long-term effects that nobody's coming back and making things better for us. So how do we make it better for the people to come after us? And I'll leave it there.
I totally have to echo that. Oh my goodness. I'm sorry, Benas, go ahead.
No, go ahead. And I was going to have Christine talk about the where that's so you have had your genetic testing now for a bit, right? A while ago. Mm-hmm. So if you need to bring it up and mention it to a provider at this point, where do they have to see it in your chart? Because it's far back, right? So I think we talked about that. And
oh yeah. So now it's not in Epic right now. My pharmacogenomics are in a note dated back into February of 2019. And so I direct physicians to go there. It's not in a language that most of my physicians can even understand. And Benas, I just called you a few weeks ago because one of my doctors wanted to prescribe a new medication. And I told him, can you please look at my PGX results and align that? He didn't know how to do that. He read through it. He didn't know how the drug that he was going to give me was going to affect me. So he said, if you have friends, find out from them, and then you make the decision on what drug. But that research had to be done through me, right? And not even to have access to that, and not even to have every physician aware of pharmacogenomics, right? I also had an incident in the hospital where this doctor wanted to know where I got this test and who performed it, and he had never heard of it before, right? So I think there's a lot there that needs to be thought about. It's not in the Epic system. It's not known by all of these doctors. And when I'm going in to ask for a specific medication, especially an opioid that is way more powerful than most people will have, they have to understand why I'm asking for that as well.
Right. Yeah, that's the problem. Yeah, I didn't think about it till you told me a while back. Where is that information hosted? Even if people do know how to read it and understand it, how do they find it? Because you're not going to go and search through all notes, right? So there has to be a better system. Then I don't know if I have the answer, but yeah,
I'm sure someone out there does.
Someone out there has the answer.
The universe.
Right. But I mean, what about the reimbursement piece of all of this? Are you familiar with, Christine, the reimbursement piece of the test?
As far as the PGX?
Yes.
Or not so much. What I can speak on really is just the benefit to the payers in paying early, right? To look at these case studies of people who have damage from medications, right? And we're treating symptoms instead of treating their underlying causes. And so for me, on that side of it, for the reimbursement side, I mean, really all I can speak to is the benefits of having this done early, right? Because I think it's something that if we were to do, steroids, like I said, a lot of these simple drugs that we are giving people, even just the pain meds themselves, we're giving people pain meds that may not take them out of pain.
Yeah.
And
that's the problem. And then they call them like the drug addict, or they're right? In pain. They're really not, and imagine what this could do for the opioid epidemic and just so many other drugs too that people become addicted to. And they say they're in pain, and these doctors do come back to them, and they say they're just, they'll tell their secretaries even. My mother was one of them, a secretary, and she would say her doctor would tell her, that one called, nope, can't see him, no more pills. But if they just did this one test, and it makes me nervous too when you say about the steroids. Two of my sons have really bad asthma and allergies, and they've been on so many rounds of steroids, and it really makes me nervous now thinking about it, because I know what it is for us adults, right, to have the benefits for this genetic testing, but why wouldn't we want our children to have it?
If genetic testing could be, if genetic testing could be done at birth, that would be ideal, wouldn't it? It's going to be very difficult to get most people on the bandwagon and most doctors on the bandwagon for it. It's such a new concept, I think.
And right now, the burden is on the patient to come in knowing that they have these variants, right? And for instance, when my mom was sick and she they didn't have time to test her for DPT deficiency when she was in the hospital. We got her blood tested the day after she died. And unfortunately, there are differences in labs too, because the lab who tested her blood, LabCorp, only tested for one variant at the time, but I'm happy to say that they now test for at least 5 variants. So it would have caught my mom's variant had she been tested prior to her treatment. And so I asked my primary care doctor in the state of Washington I wanted to have this DPYD gene test. So they drew my blood and sent it off, which I didn't know. They send off their DPYD gene panel to the Mayo Clinic in Rochester and sent it back. It was back in my chart, which I think is Epic, in 5 days. So I knew about that. And, it took like 3 days for my primary care doctor, because I wasn't a patient that was experiencing cancer and needed, they would have called right away, I think. And I had United Healthcare at the time who paid 100% of that test. So that was huge. And, this whole issue with my mom was the first time I'd ever heard the term pharmacogenomics or PGX. And so in sharing with a friend who's an OBGYN, she's like, oh, you should get a direct to consumer test. So I did, which confirmed my DPYD variant, the same one that the Mayo Clinic, but it also found other things that I metabolized differently. And I'm just kind of dumbfounded, and kind of like Christine, that whole CYP2D6, CYP2C19, phrases that I'd never heard before. I'm like, I am very aware. And the way university or my hospital in Washington has it in there, because they do not have a genomics model in their patient electronic health record, it's put in as an allergy. And it's there's a huge education piece about DPD deficiency and pharmacogenomics that needs to happen. And I know I've been talking to oncologists, but also I've been talking to pharmacists and hoping that their schools of pharmacies at all of these medical institutions are teaching about it, because it seems to me that there are so many pharmacists that know about this, even sometimes more so than primary care doctors or oncologists.
Yeah. Well, Becky, Becky's a pharmacist by trade. So what are your thoughts on that, and also testing at birth that Joanne was talking about? And maybe if you're familiar with the reimbursement piece of that test?
Testing at birth would be preemptive testing, and in the ideal world, that's what would happen. Unfortunately, on the market access and payer reimbursement side of the house, we don't live in an ideal world. And payers' arguments about preemptive testing is that for the majority of Americans, their healthcare insurance is tied to their employer, and they typically only remain in a health plan for approximately 18 months. So that payer only has 18 months to capture the return on their investment into genetic testing. Because I think we can all agree that, unfortunately, healthcare insurance is also a business. And so that's their perspective, is that they want to see that return on their investment within 18 months. So as Karen stated, patient-driven testing, and luckily, fortunately, the cost of testing has come down from where it was, say, decades ago, so that it is more affordable, so that more patients can afford testing. That's the payer perspective. That's their perspective. That's what I can add to the conversation. As far as, for example, if you have a family member who has, for example, DPYD variants that affect their metabolism of chemo drugs, then they do familial testing. For example, a payer would see that as medically necessary, typically, because another family member has that variant or experienced adverse events related to the drug because of the variant. So they would view that as more medically necessary in the preemptive state. So, before you actually need the medication. So that's just some insight from their perspective. And then for pharmacogenomics in general, not necessarily DPYD, most payers don't find medically necessary multi-gene panels because it's kind of like, I equate it to, just imagine if you went to your prescriber and your prescriber prescribed 10 different medications for conditions that you don't have already. So let's just say you don't have hypertension, but they prescribe you one just in case. Or maybe you don't have diabetes and they prescribe you a medication to lower your blood sugar, but that's just in case you need it. Payers aren't going to pay for those medications, and they feel the same way about genetic testing, in that they want you to have either your doctor to be considering prescribing the medication or for you to have already been prescribed the medication and either had a negative outcome or non-therapeutic outcome.
That's a great point, Becky. You say that. Then it got me thinking about all this testing I have to do, and I won't give my age up. At a certain age, you got to do, mammogram. At a certain age, you got to do colonoscopy. Right. So those are our preventative because they see, I see that as two reasons, and I'm not an expert in the insurance perspective, but they see that there is, cost benefit to doing it early and preventative. And there's also maybe guidelines that recommend it, and it's in there. And I don't think we have that with PGX. No, right? We don't.
That's part of the problem is that, pharmacogenomics is not dictated into any guidelines. So like, I believe Karen mentioned earlier, NCCN guidelines. For example, they don't even recommend CYP2C19 testing for clopidogrel. They don't think that's medically necessary. So many payers subscribe to those national guidelines. And until those national guidelines are changed, payers' perspectives may not be as easily changed. But, fortunately, I've had the opportunity to focus on this and try to work on market access and payer reimbursement for pharmacogenomics. And the one thing that we're lacking that we could really use more of is the clinical utility of the testing. What type of financial and clinical outcomes are achieved from these tests? Because that's what payers want to see, is the clinical utility.
And can I ask too, have we done any studies on like these average drugs in long term, right? We know that steroid causes psychosis and, joint or bone damage and all of these things. But these are drugs that are prescribed standard to so many people. Are we looking at those standard care of drugs to see how we may have damaged people? Are we avoiding that topic altogether on that payer side? Because like you said, Christina, your two kids are on steroids, right? How many people have kids who are on steroids, not just for asthma, but maybe some other condition? So, I'm wondering on the cost, if we're looking at long-term damage on some of these normal standard of care drugs.
Right. I think it, again, goes back to payers looking at how long-term is long-term for them. Because if 18 months is their long-term, then you may not see those adverse events reach their full potential within 18 months. So that's not their interest in preventing those costs. Right. Now, Medicare populations, patients stay in those in that program for many more years. They may have a different administrator for the plan, but they're in Medicare. So Medicare tends to favor longer term goals, such as what you're referring to, where the long term is longer than 18 months.
And just for a side note, I'm on Medicare myself. So I am a Medicare patient, and I have actually avoided taking jobs because Medicare gives me better coverage than most other private insurance plan. And when you get to be complicated, you've got to find options. So I think, that area of Medicare, looking into that, I do think that we should look at it for bigger populations, and how do we restructure these things as we move forward?
I have two thoughts on that. So the American Cancer Society Cancer Action Network at the end of June, where I was fortunate to speak, they revealed 9 pharmacogenomics recommendations. Now, this was specifically for cancer patients, but I have to think that it's going to ripple into primary care as well. And then the second aspect is last year, you're probably familiar with the right drug, or the right act, which was the right drug for at the right dose, the right patient. And I'm hopeful that that's going to be reintroduced again in a smaller, a scaled back version, or like cut it into 2 pieces so that they can focus on the pharmacogenomics aspect. And that really is so key for the payers and for Medicare, because for instance, like what you were saying, Christine, and in my mom's case, if they knew about this in the beginning, they would have tried a different medicine for her because she could not process this chemotherapy. But instead, her Medicare paid for her treatment, and then for her 2 weeks in the hospital, where she had round the clock care and like 5 or 6 specialists, which we know, we've seen hospital bills, that is not inexpensive. And that test, even if it had been $1,000 to test her for DPD deficiency prior to administering her chemotherapy, still would have been a cost savings. And that's just one patient.
That's correct. And, I'm happy to report that several states in the last year have passed legislation saying that insurers must pay for biomarker testing. And that includes some PGX markers. So, I believe the tides are turning, and, that's a big step that states, the legislators are seeing the benefit. So more.
And I'm looking. I was going to say, I'm looking forward to in California as well, right? We're going to the Senate next. We've already passed the Assembly side, where pharmacogenomics will be given to our Medi-Cal patients, which are our Medicaid patients for people that. And so I think that would serve a huge example for other states, right? To see if that has some answers into not just some of these conditions, but also into some of the opioid crisis that's happening. And to see how that affects, and maybe we learn lessons, right? I think UCSF is also doing some amazing things with their own PGX department there, where they are testing their patients at UCSF. And if you have a condition and you are a patient at UCSF, you can ask for that testing, and they will not bill you as a patient. They'll figure it out on that back end. And so I think when we start to see these things go into place and start to see the benefits that other places and other people are going to gain from them, I think it'll be a fast moving change, or at least I hope so.
Oh, absolutely. Anytime we have a precedent upon which others can base their decisions, that helps. Anytime that we have a case study or proof of concept with positive outcomes, that's going to help move the needle forward. So that's why those projects, such as what you described, are so critical.
One of the effects of the lawsuit that I filed against OHSU is that it did set somewhat of a precedent.
Yes.
It's been talked about, written about quite extensively at this point, and there is a fear of litigation now among many oncologists and many hospitals because they know certainly that this is definitely cause for litigation if testing isn't done. And just the cost alone for the hospital was almost $500,000 for just about an 8-day time period that David was hospitalized, compared to a test that might have been $250. And then the cost of the lawsuit and the attorney's fees as well. So I think that's going to further some action on the part of a number of hospitals. We're hearing about it.
The state of Hawaii is another example. The state of Hawaii actually sued the manufacturer of clopidogrel because they showed, and they based it on marketing. They were able to win the case based on marketing. They said that they failed to disclose the information that they had about how patients with certain genotypes, CYP2C19 genotypes, would have poor outcomes or adverse effects from the medication. And so the state of Hawaii, whose population has, I don't know if it's a majority of those genotypes or a very high number of those genotypes, they ended up having to pay for the poor outcomes from that medication. You know, they paid for the medication for their I was going to say patients, but they don't look at them as patients, for their citizens. And then they had to pay for the costs associated with the bad outcomes. So they were actually able to win a lawsuit as well.
Christine. Sorry, go ahead, Vicki.
That's all.
That's a hot topic. Christine.
Well, I was going to add to it and kind of touch on it. My damage is from medications, and people many times over have asked me why I don't sue over it, right? It has completely, I can't, the joint replacements, the brain damage, those things can't come back. But one of the things when people ask me if I want to sue people, I will say I never did. I never took that action because my physicians who treated me, they were like family. Nobody knew how I metabolized these drugs. And, me, my doctors, no one. So when we were prescribing them, we were taking a chance, right? We were keeping me alive. And sometimes those were the only options. And so I have to say, as far as like lawsuits, I could never bring myself to do it because I care about the physicians who prescribe these drugs to me. But I do look at other countries and I do look at other, I was talking to someone in India who, if someone is experiencing damage from medications, they do have to have some kind of restitution. And so for me, it's not asking for like anything other than how do we make people whole again after these things have taken place, and how do we kind of take these experiences and then learn from them? Because I hate angry advocacy, right? And I always feel like lawsuits brings in a whole nother feeling and people and all these different things where we just, for me, we didn't know these things at the time. Now we do. And so now I think if you don't do something that you have the capability to do, I think, yes, we should definitely do something there. But I don't know. I always just felt like some of these things we don't know, right? It's still science and we're still learning. And I can't be angry about these things that have happened my entire life, just, because we know things now. And so I don't know. I just would hope that we take these experiences from everybody and really learn how to move forward in a way that if we do damage people from medications, how do we make them whole? How do we, how do we give them a quality of life? So I don't know, just my thoughts on it, and you guys can all say whatever, but I loved my
hear
doctor.
you, Christine, on the lawsuit end. I understand. Like I can understand your feelings and your thoughts on that because, like you said, they were, you were close with them and they weren't educated enough and they were trying to treat multiple, it sounds like multiple, problems that you were facing. So I totally can respect and understand that. And I've never been one to, be a lawsuit, like, all right, let's go after them or, ever. But I will say, and in this particular, from the front for, the specific enzyme deficiency for the specific drug, right, for the chemo, I have to say, I think, Joanne, I'm so happy for you that you were able to, drive that and you probably sparked up a lot of awareness there. And, no one wanted to hear my story, any lawyer that I talked to, because they're like, Sloan, oh, absolutely not. But I will say, for cancer and this specific drug and how toxic it is, I think everybody should be educated on this. The doctors should know what to look for. The nurses should know when the family members are calling and begging for help within a day or two of the chemo. So, I think it's definitely, a personal thing for you. And I totally understand that you were facing multiple, issues that you were trying to address. And it sounds like you're obviously, there's a multitude of different medications that are standard of care, like you said, that don't work for you. And that's huge. And that's a whole.
And by no means, I also want to add, Joanne, good job on the lawsuit, because I think those things have to set precedents.
I appreciate the support from both of you, because I am not a litigious person at all. But I think if David's doctor had said, oh my gosh, I am so sorry that he died. Right. I feel so bad. We did everything we could. And I would have said, okay, let's work on making changes at this hospital. But they denied that that's what he died from. When I was doing my research on VistaGuard the day before he died. Yeah. So I wanted to set an example for that hospital and for other patients. And the money involved was a non-issue. I would have settled for $100. I just wanted them to make the changes, which they haven't made yet as of today. Right. I have had no evidence. We have been sending emails for 9 months, 10 months, and we've never had a response other than we're working on it. That's it. Yes, that was going to be sort of my justice, getting justice for David, making changes at the hospital where he died. So I haven't had that. So instead, I've turned my attention to the advocacy group, and we're making great strides. We've submitted several petitions to the FDA over the last 4 years to ask for them to change the patient handouts and a whole list of things that we've asked them for, including demanding testing. Of course, they've not come forth with any demands yet. We know that the FDA is not ready to do that, but they did make some significant changes to patient handouts. And so at least they've been improved and the issue is now addressed. Let's see, we've done a lot, the advocacy group audit, in terms of getting the word out. There's another petition before NCCN right now asking for, among other things, adding mandatory testing to the protocols for the treatment of breast cancer. And I think that was just submitted this month. We don't know yet what the results are, if they've honored it, if they've even read it, but the petition is quite extensive. And so that's one opportunity to get through to the NCCN. Once those standards for treating individual cancers are accepted by the NCCN and ASCO, we're making huge strides then at eventually having the FDA mandate those protocols to test.
And I think
go ahead, Karen.
what's so important about all those things that Joanne just listed that kind of piggybacks on what Christine said is, if you don't know about something, great, we're learning this out together. But they've known about the risk of toxicity and death because of DPD deficiency for 30 years. 30 years. And the National Libraries of Medicine say 1,300 Americans die every year. 1,300. That is crazy. And we've all heard the news that the incidence of colon cancer is going up with younger people dramatically. So that I can only think that 1,300 number is going to go up, which is why this importance of making this DPYD testing standard of care before fluoropyrimidine chemotherapy is huge. And however we can get the word out, it's going to has to be the NCCN, ASCO, payers, pharmacists, podcasts like Becky and Banaz, and just talking to people and sharing with people, that you meet, like neighbors. We have a neighbor whose daughter's going through breast cancer and it's now metastatic. And it's amazing that people don't know, and I didn't know before, the difference between testing your tumor's DNA and testing your own DNA. Because they say, oh yeah, my family had genetic testing of their tumor. And I'll say, yeah, but that's the tumor, right? But the human also has their DNA, which is how you're going to tell also how the medication, how our bodies work. So it's there's so much to know out there, and there are hospitals that are testing they've lost patients, and so they're adding testing, like Dana-Farber. They're testing at all of their institutions now. Dartmouth, Cleveland Clinic, Intermountain Healthcare, and these are places that are testing before administering this cancer chemotherapy because they've seen what it can do. And I've been working with the University of Washington, and I thought they had kind of put a hold on it, but I just heard that they are moving forward, because the oncologist that I talked to has seen how devastating this chemotherapy can be. So I think we just need to keep pushing forward in all of our advocacy lanes, and I applaud all of you for what you're doing. Thank you.
Thank you. And Christine, did you want to add to that?
I'm shocked when you say that they've known about this for 30 years, because, when Sloan said to me that it could, that they were going to go ahead and test for the DPD deficiency, what alarms me is the doctor said, and if it comes back, say if we waited that 10 days for the results, if it comes back and it shows she's deficient, well, we just won't give the same chemo, we'll do a different one. So what's alarming to me is if they know what the devastating effects are and how quickly, it can kill the person. Why wasn't there any, why did they drag their feet, and why did they even offer another option when it really wouldn't be,
I know it's baffling because they say it's rare and an acceptable risk. And when we're talking about 1,300 deaths in the US, that's 5 737 jets every year. So, those of us who have lost family members to this rare and acceptable risk are, crushed and just trying to make it so that this doesn't happen to other families. And kudos to University of California, San Francisco, who I met, a couple gentlemen, physicians from there at that Precision Medicine World Conference where I met Banaz, and that was their Valentine's gift to all of their patients, to test them all for 14 or 15 different genes for about 60 different medications. Amazing. There are a couple other hospitals that are doing that. So it's going to happen. We just need to keep banging the drums.
There is a doc.
Oh, Go ahead, Joanne.
Oh, I'm sorry. There is a doctor, an oncologist at the University of Iowa who does a cheek swab for $50. And that is not a genetic test, but it's a test that will indicate whether or not there is an issue. And I wish I could tell you exactly what they are looking for in it. But if they find something positive in this cheek swab, then they'll take the testing to another level and do a full genetic test. But for $50, they can rule out the need to go further into genetic testing for this particular chemo or, for this particular enzyme. So that's remarkable. A $50 test would have saved David's life.
I did want to say before anything else, Kieran, I was also at the Precision Medicine World Conference, and I saw just a portion of your presentation. I was moderating another track, but I wanted to say I stopped by and I saw you had a slide on your presentation that said what could go wrong. And after I walked away from your presentation, it was me and another woman. She was the nurse. She works somewhere else. And she said, "Why are you walking away?" And I said, "Well, I've got this to do." And I said, "But that presentation hits way too close to home." And I said, hearing that and seeing that slide of yours, all I could think was one of my friends is going to be giving that exact speech when something happens to me.
Oh.
And so I wanted to say that even just that little brief moment that I could hear your story just really touched me. And I'm sorry that I didn't get a chance to go see you after that. I was running around myself, but I wanted you to know that really did touch me. And if we can think about things in that way, like what could go wrong? Like people think nothing, right? But we really do have to think about what can go wrong and how we can fix that. We have tools now that can solve some of these issues, and we're not using them.
Yeah.
So
I think it takes providers. We have an oncologist on our medical advisory board, and he lost a patient. I think it was during his residency. And so he just will test when the new patient comes in and you're doing all these other scans, he's going to do a DPYD test. So if he is going to prescribe 5-FU or capecitabine, he's going to know in advance, and it saves lives. And so I don't know how we can put a cost factor on that, right? Or you ask people, okay, yeah, well, it's a rare and acceptable risk. But if you had your mother, if you were one of the people saying this is rare and acceptable, but if your mom was going to be prescribed that or a family member, would you prescribe that to them? Probably not. So, no. So don't prescribe it to other people. Let's do this test. So
it's an acceptable risk for everyone else, right?
Yeah.
Yes. Joanne, did you have something to add to that before I ask you guys to kind of give your last?
Right. I think we've really done a good job of covering all of the bases. I'm just still dumbfounded that there aren't more hospitals, especially OHSU, either doing testing or at least recommending it, or at least making it an issue during the intake process. The word, I think, is going to spread, and I think it's going to spread fairly rapidly within the next year. At least that's my hope.
Yeah. Well, thank you, guys. I'm going to go around and see if you guys had to, because there's a lot of individuals listening to the podcast. It could be pharmacists, pharmacy students. It could be healthcare providers. It could be organizations or different people that work within a hospital, any kind of discipline. I guess there's a lot of takeaways, but if the one thing you want them to know if they're hearing this message, I'm going to go around and start with you, Joanne. What do you want them to know?
Well, I want them to be aware of the phenomenally dangerous risk of prescribing fluoropyridamine chemotherapy if the testing is not done prior to starting that chemo. The test is simple, it's not expensive, and it's life-saving, and they need to be aware. And all of the medical providers, starting with the oncologists and certainly the oncology nurses and the emergency room staff, need to be aware So.
Thank you. Karen?
I would say the same thing. We need to make people more aware of it, and that the NCCN, they need to change this and make this standard of care. Somebody said to me, or I heard it, and somebody said, "Would you go to the eye store to purchase eyeglasses without getting a prescription to see what you need, what your eyes, because your eyes are different than mine?" No. So why would we prescribe this medicine now that we have this science? Why would you prescribe this medicine without knowing if that patient can metabolize it?
Christine?
Sure. I think that we're all on some kind of medication, or we will be at some point, and we don't know how each of those drugs will metabolize in us individually. And I think as you move forward, and even if you think of the standard of care treatments that you're prescribing to someone, to really think about that individual, how they're different from others, how even just their ethnicity could factor into how they metabolize drugs. And so really, I think it's important for us to think about those things, because even the standard of care drugs are going to have effects on normal people at some point. And I think we just need to keep sharing our stories.
Thank you. And Christina?
Yeah, I just echo what all of the ladies, already mentioned. And like Christine's story is incredible. And I just applaud you so much for, you're so passionate about everything, and you're so happy and positive and bubbly. And it's just,
she's always that way. I can advocate.
I just,
always.
For everything that you've gone through, though, for all of these years, my heart is with you. And I'm so sorry that just from that standard care, right, medication. So you're like the umbrella to our stories. We're more focused, of course, on, the, 5FU and cancer and what the effects are. But generally speaking, right, it's touching all of us, and there's repercussions, potentially devastating repercussions that, any one of us can face, or our children. So I just think, having the education and the knowledge, and learn as much as you can, and really just try to keep spreading the word. And I'm going to really try to get more involved in the AUDT group, because life is a little crazy, my family, but I really want to get more involved and really just try to share our stories and make some changes.
Well, thank you. And I want to extend a heartfelt thank you for you guys, amazing, brave ladies, for coming out to the show. I know you guys have been sharing your story over and over. So coming and sharing again here, some of you coming back on the podcast, and all the work that you guys are doing to make change, to make a difference. I'm so touched by how strong you guys are. And Christine, like I said, you're always so positive and still pushing through, all of you guys, and fighting to increase awareness. I'm really grateful to all of you. And thank you, everyone, for tuning in. We do a lot of PGXing on here, PGX science, the clinical application, the business side of it, and patients. And we hope you learned something today, if not a lot. We love to hear from you. So we want to hear from you. So let us know, drop us a line on LinkedIn, let us know, and share this link with others so they can hear the amazing story of these individuals. Thank you, everybody.
Thanks for your interest in PGX and for spending some time with us. Please share this podcast and leave us a review on Apple Podcasts or Spotify. For all of our episodes, please visit pgx4rx.com. That's pgx4rx.com.